Good afternoon. A very warm welcome to you all. I'm Mark Bowie, Director of Palliative Medicine at St Vincent's Hospital, Melbourne, and Deputy Director of the Centre for Palliative Care, and I'm the chairperson for this stimulating webinar that we are having this afternoon on the power of language. It's my great privilege to be the chair and to run the seminar today. I'd like to begin by acknowledging the traditional custodians of the lands, the many lands that we're meeting on today, and pay my respects to the elders past, present and emerging. I extend that respect to Aboriginal and Torres Strait Islander peoples who may be joining us today for this webinar. So welcome. We have very terrific guest speakers here today to talk about the power of language. Professor Jenny Phillip, Associate Professor Jenny Wheel and Dr. Anna Collins. I'll present their biographies just as we begin their presentations, but there are certainly more extensive bios of our presenters online and available at our website. The questions will be coming at the end of our presentations, our three presentations, and we'll be able to have time to have those questions at that stage. If you would like to ask a question, please, if you could use the live chat tab that you can see on your screens to be able to send the questions through. Thank you. I'd like to now introduce our first speaker, Professor Jenny Phillip. Jenny is the appointed Chair of Palliative Medicine at the University of Melbourne in Palliative Care and at St Vincent's Hospital, and in collaboration with the Victorian Comprehensive Cancer Centre. Jenny is a palliative care clinician, researcher and teacher whose particular area of interest includes improving the ways we support and provide palliative care and how it's delivered, ensuring care is underpinned by high quality evidence-based care. She leads the Palliative Nexus Research Group, which is centred at St Vincent's Hospital and across the VCCC group. So welcome, Jenny, to the webinar this afternoon. Jenny's going to set the scene and provide a historical focus into the way that we use language around palliative care. Thanks, Jenny.
Thank you, Mark, and what a great joy to be here today. Thank you for inviting me to talk, and thank you everyone for coming along. I want to talk, in talking about how we talk about end of life, I want to focus in particular on how we talk about this in the public domain, and more specifically how we talk about death and dying in the public domain. So I, like I'm sure many of you, have been struck in the past maybe 10 years about the whole change that we talk about how people have died. So when someone has died, we say they've passed away, they've passed on, maybe even just passed. They're no longer with us, they didn't make it, they're in a better place, slipped away, or perhaps lost his battle, or indeed we lost him. And for those who are dying, they're not doing very well, they're declining, things are hard for him, or he's fighting hard. In the media, the battle metaphors are very common, as you would all be very familiar. He lost his fight with cancer, he battled with dementia for the past few years. On the news, we do still seem to use the words died or death. For example, here, a particular actress lost her battle with cancer, much loved star of the small and big screen is understood to have died. However, even in medical records, we see this sort of use of a slightly more indirect language, where people, when they're recording that someone has died, they say they've passed away, or indeed RIP. So why do we do this? I think it's interesting to reflect, and I don't really know, but these are some potential answers of why we use this indirect or oblique language, or the euphemisms. What purpose do they serve? Well, it might be that they're protective. Perhaps they call it that using indirect language may cause less pain to others or ourselves. Maybe we consider it more polite. Perhaps it assists in the whole notion of denial of our mortality or that of others. And I wonder if also it sort of creates a balm of slightly bland, perhaps bureaucratic language that helps us think of death more as a process that perhaps can be managed rather than something that's uncontrolled and out of our sphere of management, if you like. But was it always thus? Well, no, I don't think that was the case. And I want to read a couple of quotes from Marcus Aurelius, who was one of the early philosophers of Stoicism. He was also one of the Caesars, but he wrote in Meditations that death, like birth, is just a natural process. Material elements combining, growing, decaying, and finally separating and completely dispersing. And a bit later, he's talking about the likelihood of knowing death, I guess, and having seen it one after another. One who'd laid out another for burial and was buried himself, and then the man who buried him, all in the same short space of time. In short, know this: human lives are brief and trivial. Yesterday a blob of semen, tomorrow embalming fluid ash. To pass through this brief life as nature demands, to give it up without complaint, like an olive that ripens and falls. Now, I'm not suggesting for a moment that all people of that time were as determined to think about death as the Stoics, because clearly that was their thing and part of their philosophy, to face this head on. However, I am struck by the language that he uses, and the very direct language to describe death. And also, indeed, some of the notion of decomposition that follows. A very naturalistic language, and it reveals some intimacy with death. People at this time know its face, have seen it before, and they know the consequences, including the disintegration, or perhaps almost earthy awareness of what will be. And when you compare this to our own language, it's certainly not bland in nature. If we look at some of the other public ways of acknowledging, and these are some gravestones that are just from the web, but you can see the older ones, the stone ones, they mention the name of the person, often something about them, and that they have died, including the infant in the middle. But the two more modern stones don't actually mention that. They give times of the lifespan and then something about the person. He was our inspiration and never far from our thoughts. And in the other sort of, I guess, public sort of area where we acknowledge this in the newspapers, older newspapers were a bit constrained because certainly in the mid 19th century, they were hand typeset, so you could only do short things, but they were all under the heading of died, and people often wrote something about the person that they loved, but had fairly direct words. In the early 20th century, things got a little more flowery, perhaps, or showy, as you can see in the middle. To return, and then I guess poetry became quite big in the 20th century, but we've seemed to have returned to something a bit more austere, and you can see again that there's not mention of died, but more something about dates and the person themselves, something, this man was much loved grandfather and great-grandfather. So why have we moved from there, where we used very direct language, to now where we are much more likely to be oblique in our language? Well, Charles Core has suggested or postulated that this change might be due in part to our familiarity. That familiarity with death has changed, our patterns of dying are different, and our patterns of care and caring are different. And to quote some of the work from Christopher Aries, who undertook a social history of Middle Ages, particularly Western European and Christian, so with those limitations. But he claims that death at this time was familiar to all. It was a very public affair where the community came together, both to care and offer comfort to the dying, but also to offer solidarity in the face of this threat of death. People knew it, they knew the signs, they were aware of its inevitability. It wasn't that they were submitting, but they were somewhat resigned to it, and the focus was on finding meaning, making it in some way comprehensible. And also, after the person had died, the treatment of the body was also the domain of the community. The cemeteries were in churchyards and churches, so places that were frequented often daily. And indeed, the cemeteries were often central to community events such as markets and the courts. And you can see, I guess, since that time, we have obviously witnessed this most extraordinary, well, we haven't witnessed, but there has been the most extraordinary change in mortality and life expectancy. So 1840, in most advanced European countries, life expectancy was around 40. gradually increased to 45 and then to 50 by the turn of the 20th century, up to 60 years by 1930, 70 by the 1950s, and now in Australia for males life expectancy is around, median life expectancy is 83 years. So an astonishing change in our expectations of life and our reduced expectations of an early death. So now death is the domain of largely of professionals. Care is professionalised. Clinicians, not the community, are the experts. The body is also looked after by the experts, the funeral directors. And unlike in this picture, now death occurs primarily in institutions, either in hospitals or in care homes. 80 to 90% of such deaths are there. And so Kane has coined the term the death-free generation, that in our community it is possible that a generation is born, lives through infancy, childhood, adolescence into adulthood, marry and have children all of their own without experiencing the death of a close family member. And so Core would suggest that over the 20th century, the view of the dead came to be seen as sort of the notion of the other. And this was not only around physical distancing in terms of how care was conducted, but also some social distancing, in that death was now sort of increasingly a bit unacceptable and a bit unmentionable as a natural process. And that the sort of disintegration of death is increasingly seen as a little disgusting, and that preoccupation with that would be morbid. And he would suggest that our language reflects this need to distance ourselves. So does it matter, if all of this is happening and am I just being sort of curmudgeonly in bringing this up? I think that my colleagues a bit later today might talk a bit more about this, but I think there are some problems with how we use this language. The battle language, which is ubiquitous in the media, as I said, also in fundraising campaigns and also in medicine, tends to emphasise power, strength, aggressiveness, and I would also suggest is fairly masculine in nature. It's evoked to counteract a sense of loss of power and helplessness, but there is this concern around what happens if you lose the battle or you're not winning the battle. Does that mean that you're a loser or a failure? And again, we have this language of having failed chemotherapy, for example. The other thing is that I'd like to bring up is that the sanitised words and the euphemisms are ambiguous, and does that have an effect? Well, I think it is possibly concerning for children. For example, if we talk about someone having gone to sleep or we've lost grandpa, then the obvious response is that we should go looking for him. And to leave those things hanging is according to the developmental level of the children, it's probably much more important that we are direct and clear so that they don't take it upon themselves or absorb some of those and develop fears or concerns relating to that ambiguity. I'd also suggest that the notion of these euphemisms when we're talking with people where English is not their first language is potentially problematic. But I just want to finish by sort of two final thoughts. One is this whole paradox is the notion that we are talking about death in terms of such as past in an era where we are exposed to phenomenal amounts of violence and death on our media, films and television, even the TV news. And how do we square those two things? And then the final thought that I wanted to bring up, as I said, I've been offering a critique of this indirect language, but I would like to just sort of perhaps step back a moment and think about how this might offer also an opportunity in palliative care. We know that all language encodes meaning, and this is shared by those people who are in the field, that the meaning of language is generally understood and agreed to us all, but it's also profoundly influenced by history and society and politics and culture and context. To share the language is to share these sort of assumptions, but often there are also subconscious meanings associated with the word that may not be immediately apparent. So, for example, the word land has layers and layers of meaning and implications. The philosopher Derrida would suggest that we can make some of these implications or meanings apparent through what he terms deconstruction. And basically deconstruction, as I understand it, is a term to create some sort of rupture to enable the implications or the hidden meanings of words to emerge and become visible to us all. And I'd like to sort of leave you with this notion that perhaps in palliative care, we are using words that have meanings that are not always visible. And perhaps some of these less visible words may offer opportunities, that perhaps we can use words deliberately to allow these opportunities for subconscious meanings to become available and new possibilities become available. So, for example, if I ask you to speak of what you hope for and what hopes do you hold, does this question create a new space for you? Does it allow new ways or new possibilities of hope to emerge into that space? So just to finish, I'd like to invite you to think about some of these words in your work and whether using them deliberately might enable new things to emerge in the clinical encounter. So perhaps you can think of some of your own, but maybe wish or contentment or freedom or even care might offer new opportunities for the patients that we care for at the end of life. Thank you.
Thank you, Jenny. We'll now move on to our second speaker, Dr. Anna Collins, and she's going to explore the public perceptions surrounding palliative care. Dr. Anna Collins is the lead of the Public Health and Health Services Research Program for the aforementioned Palliative Nexus Research Group at the Department of Medicine, University of Melbourne, that Jenny Phillip chairs. And again, as I mentioned, we'll be exploring the public perceptions of palliative care and the approaches to communication about choices for care around serious illness. So welcome, Anna.
Thanks, Mark. And I'm really delighted to be with you here this afternoon. As Mark has said, my presentation is going to offer a collection of musings around the limits and implications of language in serious illness, drawing on some of my research data exploring patient, health professional and media discourse surrounding palliative care. I'd like to begin right at the start of the story of palliative care, indeed at the time of referral, when the term palliative care is mentioned, perhaps for the first time. In this story, a young mum, here called Millie, who has a high-grade brain tumour that has recently relapsed, comes to clinic with questions about how she might talk with her children about her illness in the future. In acknowledging the difficulty of these conversations, her care coordinator, who Millie knows well, suggests referral to palliative care to help address her concerns. Millie quickly responds, saying she's coping well. She's sure palliative care is probably a good thing for those who really need it, which is not her, at least not yet, and she agrees to think about it later on down the track. Millie soldiers on, increasingly tired from her treatment, perceiving there are no other options for care. She's both looking for support and yet hoping that no one mentions the words palliative care. It's as if saying these very words will bring forward her death. So why is this? Let's consider for a moment the discourse that surrounds palliative care. And by our discourse, I'm referring to that of our patients, of our referring colleagues within the health system, and more broadly in society, including the language of our media. So here we are. The language of palliative care is described by patients, families, and members of the community. And while many of the individual words appearing on this slide are fairly unremarkable, what strikes me is that most are associated with inherently negative states of being: pain, suffering, symptoms, terminal, debilitating. And conversely, those words in blue, which we might associate with the more positive aspects or the more positive attributes, such as quality of life, comfort, help, care, are commonly used only when paired with a qualifying descriptor, such as just or only or limited to, which somehow diminishes their potential benefit. And so I think what we see reflected in this language is the inherently negative public discourse, which positions palliative care as diminished care or non-expert, non-technical, non-medically focused, a lesser treatment alternative that is just about pain relief and comfort. And I quote this patient who said, very basic, you know, just a bed in a hospital where someone's attached to a morphine pump to control the pain. A discourse associating palliative care with limited choice, when the system tells you that no other choices for care remain. Or as this patient said, when the hospital says you're dying and they're going to put you somewhere. And narratives associating palliative care with an end to possibility, being thought of as a place to wait for death and an end to hope associated with a time of dependency for people who need help. So what about the language of palliative care as described by health professionals, our referring colleagues, and even the professional societies which represent them? What I notice about the words on this slide, particularly as distinct from those previously shown, is the technicality of the language. Progressive, life-limiting, advanced, specialist, generalist, words which may evoke different meanings for different people and indeed be quite confusing, raising further questions. I also notice the absence of the words death and dying, which clearly in some contexts may be helpful and in others perhaps less so, raising their own implications. And I'll go on to speak to this point further in a moment. I think it's really interesting that the result of this discourse for referring clinicians who are ultimately on the front line of selling palliative care, if you like, to their patients in order for them to add this layer of support to those that might benefit, is this very real need to adopt a series of tactics when introducing palliative care. And this includes, as conveyed here by this group of cancer clinicians, the need to adopt and rehearse a spiel around how best to discuss palliative care. And I quote this registrar who said to provide a shield for patients and offer a gentler introduction. And this spiel, while described differently by individual clinicians, include the tactics of presenting palliative care as experts in pain, even better than me, as said by this member, appealing to the patients to consider their request to help them, the doctor, in ensuring the best approach to care, or the angle of the loved one, the notion that we're not doing this for you, but as an extra layer of support for your spouse. And lastly, the tactic of drip feeding carefully selected language, including deliberately avoiding words and the words palliative care, instead focusing on the notion of services, as said by this surgical oncologist. What about the language of palliative care as presented in the media? As Jenny already touched on, the media discourse can be somewhat limited. A retrospective media analysis conducted by our team examined consecutive articles published by The Age and The Australian in a 2-year period from 2016 to 2018. And when coding this print news content, we found that accurate and comprehensive presentation of palliative care, including the coverage of positive aspects, was not common. So palliative care was often uncharacterised, with only limited mentions as an approach to pain and symptom management, involvement of family or carers, or its positive associations with improvements to quality of life. Where pain and symptom management was mentioned, this was most often negatively presented as inadequate for relief, with narratives of terminally ill patients, usually brief accounts of sufferers, written in the third person, also common. I think reflecting the timing of this study preceding the passing of the voluntary assisted dying legislation in Victoria, we also found that palliative care was usually raised only in the context of articles on euthanasia. So the same articles more frequently mentioned a form of euthanasia, most commonly presenting arguments for than those against, and not infrequently linked to the case of achieving a dignified death. So this community-wide discourse forms the background and the context within which patients like Millie come to hospital and are asked to consider palliative care. And from my study exploring these interactions with patients when the term palliative care is first raised, what we see play out is the limits and the implications of our language in serious illness, which is at times perhaps inadequate and unsophisticated. As shown here, analysis of those patient narratives revealed that death was indeed unspeakable, and as a result, patients perceived that healthcare professionals used palliative care as a means or a framework to initiate discussions about death and dying. It was indeed understood by patients as a euphemism for their death, and the implication of this was that within patients' constructed narratives, palliative care becomes death. It's not just a euphemism, but personified to mean my death, in turn also rendering the words palliative care unspeakable. So speaking in a bit more depth about these ideas with examples from patient narratives and beginning with the limits of language. As said, the word death was commonly not spoken of explicitly, perhaps beyond ordinary available language, mostly referred to by patients using only implicit terms. In an effort to find words to describe the experience of dying, we observed patients commonly developed their own individual euphemisms or phrases, which were thereafter carried throughout their narratives. For example, in trying to talk about his death, this man with prostate cancer described, "There is a lot I don't know about, well, and I would like to know about. The red line at the bottom, you know, by such and such a date, such and such will have happened. So yes, that's what I'm grappling with at the moment, the red line." The ambiguity of our language form also limited discussion of palliative care, death and dying. As Jenny sort of alluded to, our system of language is based on the assumption of shared meaning, whereby particular words carry the same meaning for two individuals. And this means that conversations about palliative care and related topics may occur between doctor and patient, yet the two individuals can walk away from the discussion with completely disparate understandings of the intended communication. This narrative is from an elderly woman who was admitted to the palliative care hospice with metastatic lung cancer, and she described, "I thought this hospice was entirely palliative care, but I'm wrong. The doctor here says about 80% of palliative care and about 20% survive or solve their problems and go home." To which I probed, "So when the concept of palliative care was first raised with you, how did you feel about that?" And she responded, "It never was raised with me, you see, because the doctor here thought that I'm part of the great 20% because I'm making such good progress. So I don't know because it hasn't been put to me. And so I haven't accepted that I should be having palliative care." And I think this really demonstrates the importance of coming to a much clearer consensus regarding some of the terminology that we use to talk about palliative care, which is not necessarily used consistently and clearly can limit opportunities for patients. Death was also unspeakable as it was perceived by patients to be outside the realm of medical speak. Patients spoke of long-established inherent rules and processes of their clinic interactions, which they perceived did not allow for topics related to palliative care or dying. Instead, appointments were focused on treatment planning and the discussion and assessment of symptoms relevant to treatment planning. And the clinic was therefore not considered to be a space where they would think about raising palliative care or their fears related to death, with such topics outside the scope of these interactions. And once categorised dying, recognition of suffering was not perceived by patients to be the job or perhaps the interest of mainstream medicine, as this woman with metastatic breast cancer described. "No, they don't talk to you about palliative care, so you're not likely to turn up and say, 'Can you tell me about that stuff?' You go in, get weighed, they take your temperature. There's not a lot of that talk that goes on." And so perhaps, owing to the limits of language in talking about dying, patient narratives revealed the perception that healthcare professionals use the term palliative care as a tool to talk about dying, or more specifically as a euphemism for their death. This person said, "Things were getting tough and I went and saw the oncologist who said, 'I think we better talk about palliative care because your tablets aren't doing what they're meant to at the moment.'" And you can see that in this way, palliative care is helpful. It puts dying into more acceptable medical terms and provides a safe language or framework around which health professionals can talk about advancing illness and supports without naming dying. And at the same time, we can see that it's actually also a means of avoidance for talking about dying. and it's got implications. Palliative care was indeed understood by patients as a euphemism for death, as said by this man. When they said it was time to talk about palliative care, I thought, but I'm not in that category. Everybody in that category is in the same boat, and that boat is leaking. We just don't know how long till it sinks. And further, what we see within patients' constructed narratives is that the term palliative care is personified to mean not just death, but my death, as if it actually heralds dying. This person said, palliative care does immediately conjure up death and dying, and that's not something I'm willing to accept just now. I know I'm trained to be a nurse, but I'm keeping my arm's length. And so we see that the term palliative care itself is rendered unspeakable. As this person said, that's admitting that, you know, I've got a problem. I mean, I know I've got a problem, but to which I replied, I understand. So I think this data does really show how our language around serious illness and palliative care is very powerful and really does matter. At best, it opens possibilities for support, for contemplation, for acceptance, and at worst, perhaps it causes distress, reduces options, and limits hope. And I think it's not a straightforward issue. Our community-wide discourse surrounding palliative care in families, in health systems, and in the media is perhaps inadequate. And as Jenny spoke of, bounded in a culture that now lacks a response to death and dying. So when a person reacts to the term palliative care in the way that Millie did, it requires an openness, a willingness, perhaps a courage, and indeed a sophisticated set of communication skills to respond. And I think our next speaker, Jenny Wheel, will unpack some of these skills for us. So to conclude my presentation, I think the opportunity that remains is for the creative use of language to enable possibilities for care, for support, and for living fully even in the context of serious illness, to shift a person's individual narrative, and in doing so, to change their very experience of being. As Paul Ricoeur suggests from his work, Narrative and Time, while disease exists in physical terms, we interpret and transform it through narrative. Human identity is not fixed, but something created and recreated through the very process of storytelling. Thank you.
Thank you. Thank you, Anna. I'd now like to introduce our final speaker, Associate Professor Jenny Wheel. Jenny is also a palliative care physician and is Deputy Director of our services at St Vincent's here in Melbourne. She's a keen educator and has a Master's in Clinical Education and is particularly interested in communication skills and communication skills training. Jenny's going to present a clinical focus on language and its use and avoidance. So thank you, Jenny.
Thank you, Mark, and thank you, Jen and Anna. So as Mark said, things are about to get clinical, and we're going to talk about language and palliative care. So it really goes without saying that communication is central to the practice of palliative care, and more than that, it's fundamental to the safe and effective practice of medicine. There's a huge literature, many decades of literature, that demonstrate the benefit of clinical communication skills. Yet, despite all the evidence of benefits for our patients, benefits for staff, benefits indeed for organisations, they're still called this sort of subtly derisive soft skill. And they're poorly prioritised, both in the undergraduate curriculum and the postgraduate curriculum, really regardless of discipline. There's all sorts of excuses, the usual ones being time and money, but none of these really account for their curious absence and lack of priority. So by way of example of the importance of language, I'm going to focus on the introduction to palliative care, which I think Jenny and Anna have set the scene for rather well this afternoon. We teach our trainees that this is a complex clinical task. It matters very much what we say, and we've really heard that from Jenny and Anna today, and one of my clinical colleagues reflected that once we said palliative care, we can't take it back. It also matters how we say it, the process of how we say it. And this is where my focus is with clinical communication skills training. Whether we explicitly know it or not, we do use evidence-based communication frameworks and microskills, the process of communication. So I'm going to introduce you, or maybe remind you, of a couple of these frameworks. And SPIKES is a framework for clinical conversations that sort of gives a conversation a beginning, a middle and an end. Really not a spiel, as some of Anna's research was talking about. Really, these are clinical conversations. So SPIKES there's many of these, but SPIKES is an easy one to remember. And within each of these, there's a whole lot of microskills that underpin them. So the setup is really ensuring that you're having the right conversation at the right time with the right person and with the right other people present. It's really important that before we go giving information, you'll note that knowledge is very much in the middle of this framework, that we spend some time gathering information and really understanding the patient, understanding their perceptions of their illness, and understanding what they believe to be the meaning of palliative care, or what it means for them, or what their experience has been. Invitation is a really nice way of signposting that we're going to have a serious conversation or talk about something that is serious. And it also gives a patient a sense of control in a situation where they may be feeling that they have very little of that. Knowledge is very much towards the end of this, and there's a number of different ways of ensuring that we give people knowledge in a way that they can really understand it. And within the imparting of knowledge are a whole lot of microskills to give small amounts of knowledge in words and in language that the patient can understand. Emotions is down the bottom here, but something that we really attend to all the way through, and I'll talk to that a little bit more in a minute. And then just as we had a beginning to this framework for a clinical conversation, we very much have an end. And it's very important that we summarise, that we ensure that despite all our best efforts, that what we have been said has been clearly understood by the patient and the people with them, and we have some idea of what the next steps are. Another framework or a mnemonic is the nurse mnemonic, which some of you may be familiar with. And this is a number of ways. You don't have to do all of these, and it's certainly not a sequence, but it's a number of ways to sort of add to your toolbox to respond empathically to emotions. Emotions are inevitable, as Anna and Jenny have set the scene, when you talk about palliative care and when you talk about end-of-life care and perhaps even death and dying. Some people feel that responding or acknowledging emotions can be like opening a can of worms, but really the literature says very clearly that to be effective, you need to address emotions. There's no point continuing to give cognitive information to someone who's feeling highly emotional. So it's very important that we respond to emotions. This is a way to be efficient and effective in the clinical communication. And these, many of which you'll recognise, are ways of responding to emotion during a clinical conversation. As I said, within the frameworks, and I've shown you just a couple of frameworks, there are microskills. And again, I've just picked out a couple to sort of demonstrate the points about the importance of process to you. Tell me more is a really useful phrase, and one that I often fall back on when I'm really not sure what else to say. It's very facilitative, it's open, it's curious, and it's great for clarifying if someone says something that you don't quite understand. So tell me more or variations are very useful. Ask, tell, ask is another microskill that is very useful when giving people knowledge. It really reminds you to give small pieces of information and to be constantly checking in with the patient, constantly checking in for understanding, making sure that the language that you're using is clearly understood, and also checking for emotions. Following cues is really important, and there again, there's lots of data to show that this is more effective and even more efficient than following your own agenda. So rather than giving your spiel, it's actually very helpful to gather the information at the beginning about the patient's perceptions and then follow their cues. And these cues can be verbal or non-verbal, subtle or overt. and you really need to look for them. They could be a posturing, they could be a look, they could be an anxious twisting, a wringing of hands, or they could be sort of verbal circling or repetitions during a conversation. So now if we look at mapping out the introduction to palliative care, I can show you that the process really does matter. And you can see the spikes here. So it's very important when we talk about palliative care that they know that we're coming, that they don't find themselves sitting in a palliative care clinic surprised, or sitting in a bed surprised when the palliative care team come in. And it's very important that the right people are present. These are important conversations and really absolutely urgent. It's worth taking the time to set the scene and make sure that people feel supported and safe when they have these conversations. Perception and gathering information is absolutely critical. We need to know what they know about their illness, what their understandings are about their future, and what their understandings are about palliative care. So we want to hear what they have to say. The invitation, as we said, is very important. We want to ask if it's okay to talk more about how palliative care might be useful for them. And this gives them a sense of control. And rarely are these conversations urgent. I think that's worth emphasising, that if it isn't the right time or the right place or the right people aren't present, it's much better to put these conversations to one side until the right people can be there. Knowledge is very important. So this is where we start to get to the spiel, but really it shouldn't be a spiel. It should be a whole lot of ask, tell, ask, or chunking and checking. It's very important that we avoid euphemisms, we avoid jargon. If the patients use euphemisms, that we unpack them and understand them, and that we try and use words that are mutually understood. And very important that we use the words palliative care. They will come up, if not in their encounter with us, then in their encounter with others. And that we're brave and use death and dying if that's what we're talking about. We need to notice and attend to emotions throughout and acknowledge that our conversation won't be efficient or effective if we don't. And then we need to make sure that we have an end, that we summarise our conversation and clearly outline the next steps. Despite all the best approaches and all the frameworks in the world, this remains a challenging clinical communication task. And the responses can be unpredictable, or perhaps, given what we've discussed today, very predictable. And I have here some of the heart-sink phrases that you quite often hear as a clinician, and I'm sure will resonate with those of you who are clinicians. And how do we respond to these? Well, I hope that as you read them, and perhaps now you reflect on some of the words of the patients Anna interviewed, you see that there's actually an opportunity in all of these for a greater understanding of the patient and their perceptions of their illness. I feel like I want to say, tell me more when I read each of these. I think there's an opportunity to use some of the words that are here, like hope, which Jenny spoke about. We can absolutely join our patients in hoping for the best while we prepare for the rest, very much aligning ourselves and joining them in what they hope for their future while putting in place plans for maybe if the future doesn't work out quite the way they hope. Another useful statement is an I wish statement. Again, thinking about the language and what that means. An I wish is a very aligning statement, but it also puts perhaps what they're hoping for very firmly in the realms of a wish rather than a reality. So a very powerful phrase and a very useful phrase to respond to some of these, depending, I suppose, where the patient's up to in their particular illness journey. So I'm going to finish there so that we have time for questions. And I'm going to leave you with a quote and a key message. So how we communicate matters in palliative care and indeed in clinical medicine. And with a quote from Bachman, "We will never meet everyone's expectations, but the skill and effort we put into our clinical communication does make an indelible impression on our patients, their families and their friends." Thank you.
Great. Thank you, Jenny, and thank you. Well, now it's the opportunity of the audience to ask questions, and please use the live chat tab to ask your questions. We've had a couple come through already, which is great. And I thought actually it's very opportune, finishing off with Jenny. I thought whether we could ask you, Jenny, to answer. We've got a question here around, in the choice of words, do you consider cultural aspects, and do you personalise these words accordingly?
Absolutely. And so I think that's why it's so important that before we jump in with our spiel, that we take the time to do the information gathering and really understand the patient perspective. We really want to hear the words that the patient uses, and it can be a very useful technique to mirror those words or to explore those words. We really want to align ourselves as much as we can with the patient. So I think the answer is absolutely, and that's why it's so important to understand the patient and understand them and how they use language before we jump in with our language.
Good. I wonder, Jenny, there's a comment that's come through which really says about that people are put into categories and dying becomes death is in the dichotomy of life and death, and perhaps why the word hope is also a loaded term, because hope could mean no hope. Do you think that's a valid comment? And what do you think there are different examples of different language that can sort of explain this?
Which Jenny were you hoping for, Mark?
Oh, sorry, that's a good point. I was thinking Jenny Phillips, sorry.
Thanks, Mark, and thanks for the question. It's actually sort of quite tricky to answer. I think that when I use hope, I tend to ask people to frame it in a way of the things that they may hope for, and some of those things will be big, existential, perhaps unrealistic hopes, and some of those things will be small, everyday sort of hopes. And I think that they serve different roles in our lives, the big things that we hope for and the smaller things that that might be of less import but are readily available to us. And I think that actually achieving and framing some of the smaller things can mitigate if the really big thing is not available to us. So I think that actually I tend to see hope as generally a more positive word and less dichotomous than perhaps the questioner frames it as such. I wonder if some different language, I was interested when I was sort of thinking about this talk, I was interested in the notion of care and what that might mean for someone. And obviously you can be cared for, but you can also care. You can be cared for yourself, but you can also care for someone else. And they offer us a different, I think, meaning. And I think that is also potentially a very useful thing because to care for someone else, in fact, I would also suggest that to be cared for is a contribution, but certainly to care for someone else is also a contribution. And so, even in advanced illness, there is very much a contribution that everyone can make and value. So, I guess that's the sort of thing I was trying to get at in the ambiguity of language, less around dichotomy and more around other ways of framing it.
Great. Thank you, Jenny. We've got an interesting comment here, and it says, which I think we all would understand, that we don't really see death that often nowadays firsthand, but we do see a lot of death in our entertainment. And really, the participant is just asking the question of wondering why. And I wonder, Anna and the rest of the panel, if you would like to maybe have a go at answering that. Why is it that we see so much in entertainment, but really don't see it firsthand, but we still have such trouble talking about death?
Thanks for throwing that one to me, Mark. It is an interesting point, and I think what strikes me about that comment is that yes, you do see deaths in entertainment, certainly, and yet when we think about death that you might see in the clinical context, they don't necessarily align. The everyday death of the, of my nan last year, or of someone's loved one, or of, it's very ordinary. It's very perhaps undramatic. It just sort of unfolds, and it happens. For some, of course, perhaps that experience is different, but I think that the death that you see in the media is very different to just the quiet, everyday process of dying that happens for the majority. And so we don't see this reflection of what is, and therefore I think when approaching it in a personal context or for a family member, they don't know what to expect. They're expecting these big moments that probably never happen. And without, a very skilled communicator and a skilled clinician who can preempt that those big events might not happen, and therefore pay attention to the ordinariness of those moments, they can be missed. So I think that's what strikes me about what's seen in the media versus the everyday realities.
Thank you. Jenny, Phillip, I'm just wondering, a question here. Things like deaf cafes are becoming more popular, and do you think that's maybe a conduit for people to become more familiar and the community more able to discuss deaf and related matters?
Thanks, Mark. I think it is fascinating, isn't it, that I think that there is once it's made safe, there is sort of a maybe not a hunger, but a great interest in engaging in some of these discussions. And I certainly understand that that's part of the reason for setting up the deaf cafes, is to refamiliarise people and reclaim that phase of life. As Anna said, it's sort of, in the movies, it's a bit performative, whereas actually, most people will go about it, I think, with a fair bit of humility and normalness. And I think that if people are able, if a community is able to own it in some way, then they can, and talk about it, then it means that what does it mean? It means that it's more approachable within the community, and perhaps it doesn't have to always be done out there by someone else. And I guess it also opens that possibility, as I raised in my talk, of the community coming together and solidarity in the face of this thing that's death.
Thank you, Jenny. And actually, I've got another interesting question for Jenny Wheel. Often patients are feeling anxious, depressed, a little scared and stressed. What sort of compassionate language would you use to try and sort of ameliorate the distress that they're feeling when you're starting to talk about these issues?
Thanks, Mark. I think it's very normal for patients to have an emotional response to these conversations. It's probably also quite normal for clinicians to have emotional responses to these conversations. And I think it's very important that we approach patients empathically, that we understand what their worries are. And some of their worries are very big existential worries. Some of the worries are things that we can manage much more readily. And so I think it's most important not to make assumptions about what the worries are, but to spend some time empathically exploring them. So taking time, sitting with a patient, following their cues, understanding and exploring, and then I think it gives you a great place in which to talk about what palliative care can bring, rather than it being sort of this idea Anna brought up that I thought was so interesting of diminished care. We can actually talk about all the things that palliative care can be, and how palliative care can perhaps ameliorate some of these worries.
Great, thank you. We've got a couple of comments that are a little bit similar, and maybe to direct it to anyone in the panel if you like, but a couple on saying things like communication is all about trusted therapeutic relationships, that people who work in palliative care tend to be people that are more likely to speak in language that's relatable, and so really just to hear people's thoughts on that maybe the importance of that sort of therapeutic and trusted relationships in care and talking about palliative and end-of-life care.
I'll have a quick go at it and then handball it over to Jenny, I think. So I think, yes, that's true, that a lot of our therapeutic endeavour is built on a relationship and trust and openness within that relationship. Having said that, I think that you can create that communication space fairly quickly and fairly readily. And I think by using some of the tools and approaching with an openness and an openness to the other person as a human being can build that relationship very quickly. So maybe I'll hand over to Jenny at that point.
Yeah, thanks, Jen. I think that's very true, and I think it's important to recognise that communication skills aren't just about being nice or being innately skilled. They're actually all things that we can all learn. We've just got to take the time and I suppose give them the priority, which is really my crusade, I guess. I think that we shouldn't excuse others for not putting the time in or for not taking the time to learn the skills. It's obviously not a great interest for everybody, and I think you're probably right that palliative care clinicians find this stuff interesting and find language and other things interesting. But these are really core clinical skills that we can all use. They're very attainable, as you've seen today. The frameworks are not tricky, and relating to people is something that you can learn. There's no real magic to it. It's you just need to do some experiential practice and training, and you need to keep having opportunities to train and practice. It's not sort of enough to just watch, and you actually need to practice. And so it really is important that those of us in the field encourage and develop those opportunities for our juniors to learn and train in communication skills training.
Great. And look, there's been a couple of Sorry, Anna. Go ahead.
I was just going to add, Mark, that I guess just a comment that, often these conversations around introducing palliative care are happening upstream by colleagues who are very skilled and not focused on palliative care. And so I guess there's that point that those clinicians might know and might have a relationship with the patient for many years in the case of oncology, for example. And from a patient perspective, sometimes that relationship could actually get in the way of having these discussions, in the sense that they felt if they were to show an interest in palliative care, that would somehow be interpreted as a disinterest in aspects of pursuing the next clinical trial, which was a competing agenda. So there is this thing of how do we broaden the communication interest, not just for palliative care, but of course to other settings where these conversations should happen across an illness course.
Great. Thank you. Look, I'm mindful that time is ticking over, and we've got quite a lot of questions in the question boxes and so forth, and a few comments really just commenting on people that are skilled in this space, but really we need to draw the webinar to a close now at 5:15. So I really want to thank, first of all, our audience for their participation, but really to thank our speakers, Jenny Phillip, Anna Collins and Jenny Wheel, for their participation today and their commentary. And so many, many thanks indeed. There's a few quick people asking about availability of slides and presentation. This has been recorded and the presentation will be actually on our website in a few days' time at the Centre for Palliative Care. So really, it's really to say thank you. We certainly look forward to seeing you again in the future and to really appreciate your participation this afternoon. So thank you very much. Thank you.